Anyway, this talk is on therapeutic hypothermia, which has been coming and going for years. I practice emergency medicine in 8 different states, and I've seen every protocol of every hospital in those states, and they're very varied, which proves that this is an emerging technology that has a long history of success in the past. I used to have a really nice name, but it has denigrated over the years. Now they call me Edmond. Unfortunately, it is no spelled backwards. So I have a microblogging site on Twitter, which you can follow and follow all the stories. So let's look at the scope of the problem. Cardiac arrest accounts for close to 500,000 out of hospital. There are about close to 500,000 out of hospital cardiac arrests just in the U.S. And roughly 1/5 of that will receive resuscitation. Of that, about 40,000, or a little over a third, will have a return of spontaneous circulation. And these are the guys that will suffer the post-cardiac arrest syndrome, which is a constellation of effects of hypoxia and revascularization and all that. The main sequelae are neurologic side effects. Now, of the 40,000, there are about 30% that are discharged. And what kind of shape they're in? Not very good, because over 60% will have cardiac or neurological dysfunction. And the cost is very staggering. Per patient, you will accumulate up to $300,000 in the first 6 months. So I'm a big Game of Thrones fan, and this guy is Jon Snow, who, if you've read the books, this is the last scene where he is stabbed by his people. He's supposed to be the head of the Night Watch. Fortunately, this happens in ice. So we, up to this point, do not know if he is dead or alive. But you know the old adage, you're not dead till you're warm and dead. Now, there's another guy named Kevin Everett. In 2007, he played for the Buffalo Bills, and on the first day of that season, on a kickoff, if you watch football at all, on the kickoff, they just hit each other full bore, and he suffered a neck injury. And at that time, he went to the University of Buffalo, where he was cooled down to about 33 degrees centigrade. And 6 months later, he was walking. He suffered a C3 fracture, or C2 fracture. So, I don't know if you guys are familiar with this, but in the old days, people just woke up from being dead. So what they did was, to be sure, they'd have these people in coffins with a hole and a piece of string tied to a bell. And this is where the phrase, "saved by the bell," started. I thought growing up that is from boxing. You get knocked out with 5 seconds left, you're saved by the bell. But apparently, this is the original purpose. Now, therapeutic hypothermia emanated from that, and in 2002, there were 2 big studies. The first one is from Australia, where they had 77 cardiac arrests that were resuscitated, and about 50% had a favorable outcome with good neurological side effects, as opposed to the control, which had about 25% favorable outcome. A larger study was done in Europe, where they had close to 300 patients and had virtually the exact same results. So this got everybody excited about therapeutic hypothermia. So protocols started popping up everywhere. And true enough, there is a benefit. The problem is, it is very time limited. In the emergency department, if you are not set up, it's not going to happen. And if you're set up and it quickly happens, then you really see some good results. Now, for the next half hour, I will talk about the Krebs cycle. I don't know about you guys, but every time I see this diagram, I get a little PTSD. Anyway, let's talk about the Fanta Physiology of cooling. Now, everybody here knows that without oxygen, we all die. And tissue hypoxia mainly leads to the loss of glucose and ATP. And the neurotransmitter glutamate is released. Now this causes a neurotoxic injury or cytotoxic cell death. So these effects are mitigated by hypothermia. Now, another result of successful resuscitation is a reperfusion injury. Apparently, imagine a tropical rainforest that is all of a sudden devoid of water and it's dried up. And about 5 minutes later, a tsunami comes over. Now you have an overflow of water, and that causes more damage than some of the original injury. So when a cell gets hypoxic, and all of a sudden you feed it with a lot of oxygen, you get a lot of oxygen-free radicals that cause oxidative damage. The other problem is the body will try to heal itself, and you get a large flux of inflammation, and that inflammation is actually toxic, especially to the neurological tissue. There are parts of the brain that are more sensitive than others, and if you've known some people that have had hypoxic injury, their memory is kind of sketchy, even if the rest of them are okay. Now, what is the target temperature? Most studies target between 32 and 34 degrees centigrade or 90 to 93 degrees Fahrenheit. And again, these are based out of the earlier studies. Some studies have come out where they try to go cooler than 33, and really there's no added benefit. And you cool the person for about 18 to 24 hours. Now let's look at the indications. You have to have a return of spontaneous circulation from presumed cardiac arrest. Now there are a lot of people that have, that have gone into cardiac arrest from drowning and stuff like that. Those are candidates. However, it has to be mainly a cardiac problem. The GCS has to be less than 8, and if you think about it, these people have to be intubated and cooled to prevent shivering, and you have to put them down. In the original studies, they required people to have good hemodynamics, systolic blood pressures over 100, but the later studies show that, that there's permissive hypotension, and as long as the hemodynamics are fair, you can include them. Now look at the contraindications. Recent major surgery because of the risk of coagulopathy, sepsis, and coagulopathy. Pregnant women are excluded. The terminally ill are also excluded. Of course, if you're already hypothermic, you warm those people up. And for some reason, they've done studies in kids, and it does not work in kids. And I think the main reason is the mechanism of cardiac arrest in kids is quite a bit different from adults. And so it doesn't really quite work that way. So here are cooling methods. You have a surface cooling pad, and you have a water circulating cooling pad, and there's an internal catheter-based endovascular cooling pad. There are studies where they put an esophageal cooling mechanism and a bladder cooling mechanism. Those studies have not panned out so far. The cost of these products are quite expensive. Now, one of the more popular is the catheter Alcius CoolGuard 3000, which is this machine that looks like R2D2, kind of. It costs about $5,000, and it's a catheter that you put in the femoral vein, and you cool it through this machine, and it directly cools the blood. And this is a Cincinnati Sub-Zero that we used recently. It is quite a bit more expensive because there are other uses. We use it in hyperthermic patients from malignant hypertension, hyperthermia, or methamphetamine abuse. It is very expensive. It is about $20,000, and if you don't have Ishwar on your staff, you probably won't be able to afford it. However, ice is very inexpensive. Unfortunately, ice is labor intensive, which applies to the Philippines. You know, if you just put ice in the highly vascularized areas like the neck, the armpits, the inguinal areas, you can cool down the patient fairly quickly, although it's a little bit slower than the other machines. And this you can do anywhere as long as you have ice available. When I was making this slide, I wanted to have these in different shades of gray, but I didn't think anybody would get it. So, there are $50. Let's look at the adverse effects. There are very few, fortunately. Now, since we've studied therapeutic hypothermia, this is about 13 years of studies, only about 29 patients have had adverse side effects. And that's roughly 1% of all patients. So it's very safe, as long as you do it right. And the main side effect is bleeding from too much hypothermia. Obviously, the endovascular machines will cause infection, deep vein thrombosis, and in patients that are congestive heart failure, that we run this risk because you use a lot of cold saline. Now that was emergency medicine management of post-arrested patients, which is what I do. The real trouble or the real work begins after they're transferred to the ICU because you have to monitor for a lot of variables, electrolytes, coagulopathy, and the old, resuscitation. So, sorry. So, there is my thought. And once you get transferred to the ICU, the fun has just begun. Thank you.